But the family was great and they managed until rambutan season came. Yeah, so
That's so specific.
yeah, so there was a rambutan tree just in front of Dad's house, and each time the rambutan bore fruit, Dad, who was 92, would climb the tree.
Oh, so back to his childhood.
Exactly. And they came to me and said, Doctor, we want medicine. And we want medicine that will stop him from climbing trees. Exactly. So the answer to that is that there is no medicine to stop you from climbing a rambutan tree.
Hello everyone and welcome to our episode of Clinically Speaking Podcast. I'm Marie, your host for today.
I'm Evelyn. I'm also a pharmacist and also your host today. And today we have a very special guest here, Dr. Farhan. Dr. Farhan, would you like to introduce yourself to our audience?
Sure. My name is Dr. Farhan and I'm a geriatrician. I specialize in seeing older people, and that itself is something special and interesting.
So maybe you can tell us a little bit about what it means to be a geriatrician. Like, at what age does it mean to be like old enough to be like under the care of a geriatrician, and like how different is old people that you need a special doctor to be looking after them?
So geriatrics is a poorly understood specialty because all doctors should look after older people.
True.
So when I became a geriatrician, my parents didn't understand. They said, all older people have many medical problems, and all doctors should be able to look after them. So I always say, give them a high five. So the 5 M's that describe my specialty would be the mind. We look at mood, that includes memory. So a lot of older people are very concerned about their memory. I'm not sure about both of you. I'm sure your memories are excellent.
Like cognitive part to say,
exactly,
right?
correct. And mood, mental health is a very big thing. So that's the first M, where we talk about the mind.
The first M is already 3 M's.
There are more M's coming up. So the second M is mobility. As you know, older people are prone to falls. So we look at bone health, muscle health. The third M's are what both of you girls do, which is medications. Yeah, how many how many medications have your older people or your older patients consume?
Too much. Yeah,
exactly.
The Metcon list is like
polypharmacy.
You're right. Yeah, I mean, you look at the page, it's a few pages of medications. So my patients can be on over 20, even up to 40 medications.
Yeah, because of like all the chronic conditions.
If the medicine are so full already.
Exactly, and not to mention the supplements, the eye drops, the creams, PCM sometimes. Yeah, so we do what we call medication therapy management, reconciliation, that's right. The idea is to give you what you need and to stop taking what you don't.
Like de-prescribing some of the unnecessary medications and also to reconcile everything to make sure it's really tailored for the patient itself.
Exactly, because you imagine you go to see a doctor, right? People just add more and more and more. Does a doctor ever say, okay, stop this medicine?
They don't dare.
Exactly.
That's the main thing. Like, they feel that if the condition is controlled, then they don't want to remove it. They don't want to be the one that is taking away medicine and potentially cascading something.
You're right. Yeah. So they feel that this is a steady state. But that's not entirely true. Just because you started a blood pressure medicine at 40 or 50 doesn't mean you need it forever. So medications should always be reviewed. So we've done 3 M's. So the fourth M is multimorbidity, because older people are very complicated. As they go through life, we accumulate experiences. We also accumulate medical diagnosis. And the last is really important. It's what matters most. As we reach the end of life, talking about advanced care planning or palliative care, comfort measures, these are the things that we need to start discussing. Yeah, so that explains my specialty, the high five, 5 M's.
High five.
Yeah.
So what makes you feel like geriatric is something like, we can call it your calling?
Okay.
What makes you feel so like you opt for this specialty?
Well, to be honest, there's a story. When I was a medical student, I was attached to a GP. He was a very prolific GP, very well known in the community, and he was a specialist. Yeah.
As a GP?
Exactly. Yeah, and he trained in the US. He was an internist. He did internal medicine. Yeah, so he told me, Farhan, what sort of doctor do you want to be? Do you want to know more and more about less and less? If you want to do that, then you'll be an organ specialist. Like
More and more and less and
about less and less,
Wow.
exactly, right? Which is, of course, specialists are important, but it would be studying the eye, being an eye doctor. You'll know more and more about the eye, but you'll be less and less about everything else. So he told me the only doctor who would know more and more about more and more is an internist or a generalist. And that's why I decided I wasn't interested to spend my whole life studying the heart, even though
that certain specific organ. Yeah.
Exactly. I really wanted to know more and more about more and more.
Would you say that being a geriatrician like a recognized specialty? I think we hear very little about it, so it's just good to like clarify. It's a specialty.
Yeah, so it's a very good question because it's considered quite a young specialty. Perhaps in the 1970s when it was first started to gain traction. Yeah. So compared to being a surgeon, we've got surgeons since the medieval ages. Geriatrics is relatively new. Yeah.
So maybe you can share with us a little bit about your journey to become a geriatrician, like how long it took and what was it like setting up your own clinic and all that.
I went to NUS and I graduated in 2006. So that's 5 years of medical school. I was in an old training program because now it's residency, but the old training program was a 6-year journey. So at the end of 3 years, we took an exam, and then at the end of another 3 years, you take an exam and you become a geriatrician.
So many exams.
So the training itself is like very tailored to train all the doctors to become a specialist in geriatrician like program, is it?
Yes. So the entry point is actually internal medicine. That's where you learn everything. That's the first 3 years. And then you take on another 3 years where you do geriatrics. You can use it as an offshoot to do palliative medicine. Because palliative or end-of-life care is part of the work that a geriatrician does.
That's pretty interesting. Yeah. So after that, you continue your practice in a hospital setting first, like to review more and more patients, and then to also load up your experience or like reviewing patients' condition and everything, right?
Yes, that's right. So I started my practice last year, and that would mean that from 2006 to 2020, how many years is that? I was in hospital, and I realized that there's a big need in the community because older people, they come to hospital when there's a big problem. They've had a fall, they've had a fracture, they have acute illness. There are many complications, but there's so much that we can do to prevent that complication. So the need in the community is great because of our aging population, and that's when I decided that I would have a community-based geriatric practice.
Yeah, actually, if people, let's say an elder person, they fell at home and then they go to the hospital, they actually will see the orthopedist or they will see like the very specific specialty. When does the geriatrician get called in?
So that's also a very good question because falls, fracture, and the older person, they are very vulnerable to bad things happening in hospital. And so now orthopedics and geriatrics, they are a happy collaboration. In fact, it's standard of care now in many institutions to have an ortho-geriatric team to manage all hip fractures because we know that hip fracture, they're at high risk of dying. The mortality rate is up to 40% in a year.
It should be well taken care of.
Exactly. So the orthopedic surgeon does the surgery and the geriatrician manages everything else, the antibiotics, the medications, the drip, the
Post of
rehab.
care,
Exactly.
stepping down the care.
Exactly.
So what do you do in the community-based clinic? Like let's say in the hospital, you're looking at all these acute cases. So in the community-based, when people come out of the hospital, do they come to you, or like how does that work as a community-based clinic versus a regular GP, for example, if someone wants to see a GP to manage their comorbidities, how does it?
So patients get to know of us. They come to us through various means. Firstly, we're really along a busy road. So I started when I opened, I started seeing children, people who fell outside my clinic. There was one bitten by a spider. But slowly they got to know that my specialty was in older people. So they brought their parents and they told their friends.
Like words of mouth.
Exactly,
share around.
exactly. Yeah. What makes it unique is that our team, it's interprofessional. So I have a pharmacist on board as well who helps me with the medication management. I have geriatric trained nurses. We have physiotherapists, psychologists.
All in clinic.
Exactly.
Wow.
Yeah.
Okay. Yeah, that's very comprehensive. And
It's like a mini medical center.
yeah, it's helpful. It's helpful because it's so tedious. Let's say when they hear like, oh, I need to be referred to go rehab, and then it's like somewhere far away across the island, and they have to go there, and they're like elderly.
Exactly.
And it's hard for them to
Sounds like a
Exactly.
one-stop concept for them.
That's right. Yes. You read my website.
A strong advocate for
Yeah,
Alami's clinic.
Exactly. One-stop shop. That's right. Yeah.
Yeah, and then aside from that, I also feel because my family, we also have like elderly to take care of, so I also kind of understand their mindset when you talk to them and say, "Grandma, let's go to hospital." They will have that kind of like inner fear to overcome.
Exactly.
And then when you say like we are just going to clinic to see the doctors that you normally have a follow up, it's a lot more comfortable, and then they can bear with it a lot better.
Exactly.
Yeah, so this is
Exactly.
also what your community concept comes in, right? I
That's
guess.
right. Yes. So they're always worried they step into hospital, then we will imprison them.
Yeah.
Like they will never leave because the bed is just there. Okay, from clinic you go. you know?
Yeah, and they
so-
also do hear that. I mean, there's a lot of worry for elderly when they go into the hospital. There's all these like hospital based diseases that
Yes.
it's actually really dangerous for them lah.
That's right. Yeah.
Like infections and a lot of things that they are very scared of as well.
Exactly. Of course, the risk of delirium or confusion is there as well in a new environment, especially when the mind is not normal. They're at risk of suddenly being very confused, and that really trips up the care as well as the recovery.
So I guess for your community clinic, is the concept is more of like you are like a contact person. So whenever they feel like the elderly is not okay, but they
Yes.
need someone to maybe triage the patient first to
That's
have a look
right.
at the symptoms before really refer to the hospital, you would be the point of contact.
Correct.
So you actually step up or step down the care
Exactly.
itself, right?
Exactly. Yeah. So sometimes even that is difficult because they resist. Like, there's nothing wrong with me. Don't bring me to the
Yeah.
clinic.
Like in denial mode.
Yeah. So at times, I end up going to the home. Yeah, so the
so-
family calls because they see that there's a need, especially if there's dementia, for example. Sometimes there is a bit of paranoia or denial, like you mentioned. Then I have to go and fish them out. Yeah. Usually when they get to know me, then it's easier. They realize that it's not so scary.
It's kind of like a family doctor concept because you're close to your patients and the family, the caregivers as well. And then whenever they have any concerns, they can just give you a call, and then you kind of know the conditions a lot better, and then you kind of like following up through the cases and everything, right?
That's right. Yeah.
It's
So
a pretty holistic care plan per se. So Dr. Farhan, previously you mentioned that it's actually quite we would say a new specialty as compared to other specialties out there, right? So have you been seeing any like updates or like new things that they have been implemented in like the healthcare infrastructure so far?
well, Healthier SG is the
Oh yeah, that's
big
like
thing.
healthy one. That's the biggest one so
active
far.
aging.
Yes, exactly. I think it's a move in the right direction. The idea is to have that GP that you are in contact with, and that GP for younger people would encourage you to go for your recommended screening tests. And as you approach middle life, which both of you are very far away from,
Soon,
Coming soon.
sometimes chronic disease because of lifestyle issues set in. So then we want your chronic diseases known, you've gone for screening, and then managed well. And that really gives you that healthy dollars in your bank to give you the best possible last decade. Because what we want is, we don't want to live forever. If you ask anyone, do you want to live till 150? Yeah? A lot of people would say no.
Tired lah.
Yeah.
It's like live with disease for like very long. They probably also feel like they will be suffering for quite a long time. But how
Exactly.
to like live with like good quality of life?
Correct. Yeah. So we want to shorten the period in disability. And that means really taking charge of your health, and Healthier SG is a great initiative.
Okay. But how do you feel that ties in, let's say, with your practice? Do you see many people coming in like asking about Healthier SG, or do you feel that, like, I mean, it's kind of in its budding stages now, but do you think that will like translate to something good in the future?
Well, health is a journey. Yeah, and it starts from young. I have a young family. I have 5 children. So that healthy eating habits, it really starts before the age of 5.
How you inspire your young kiddos to start everything since young, right?
Exactly. So I had a family member offer candy to my toddler, and then she says, "No, Mama says sugar is not good." And, so that's true for all ages. Sugar is not good. So I see Healthier SG incorporated in a way that you need to be in charge of your health. You need to take charge of it. As you get older, then sometimes that family member has to take interest and make sure that your parent or your grandparent is on track. Yeah, so Healthier SG is that whole journey, the trajectory. So currently, I have a GP who works with me, and he sees a lot of the younger people, just getting them started on their healthcare journey.
Yeah. I feel like the awareness efforts and everything is like so far so good, and then it's like slowly picking up on the
Yeah, so it really sounds like Healthier SG has really set the whole stage for Singapore, especially as the whole population ages, right? Maybe things will get better for us when we start to get older, when we age. Yeah. So I think besides like trying to get the patients themselves to be healthy and all that, I think for geriatric patients, older patients, usually it's the caregivers, like the kids, they are bringing them to the doctor and saying like, oh no, this my parents are experiencing so and so. So like caregiver burnout and like trying to manage the caregiver is also really important as a geriatrician. Do you feel?
You're right. So my patients, they are looked after by children, sometimes by their spouse, and their spouse is an older person too.
so they manage themselves and also at the same time manage the spouse.
Exactly. But of course, they with support and with the love in the family, it's a difficult job, but people still strive on.
And it will be a long-term like commitment to take care of the family members, right?
Exactly. But sometimes there are crises. So for example, when mom or dad starts having memory issues, for example, because we know that dementia is a common condition in the older person, there can be all these unusual patterns of spending and
Spending money.
Exactly. Yeah. So I've had family members come and said, "Okay, doctor, I want you to look at this bank book." Okay?
That's the evidence they bring to you.
Yes, exactly. So you see, initially it's 250,000. Now in less than a month, it's 150,000. Yeah. So
They splurge on
What did they buy?
exactly. Yeah. So there were just large purchases. Perhaps it was scam because they are vulnerable even without a memory problem or without dementia. I mean, even younger people can fall
younger people
for
can get scammed
exactly.
too.
So at the end, the family member asked me, where do you think the money went and how can we get it back?
Please ask the police.
So I've had all these situations. I had one unusual case where this older gentleman was escaping. So no matter what they did, they couldn't keep that at home. So they would change the locks, make it more complicated.
Wow.
Yeah.
That's intense.
At one point of time, they gave up because they were so afraid that he would harm himself. So they just relied on neighbors. Whenever the neighbor would say, "Oh, I've seen Dad walk past," then the daughter who lives nearby would come round.
Oh.
But the family was great and they managed until rambutan season came. Yeah, so
That's so specific.
yeah, so there was a rambutan tree just in front of Dad's house, and each time the rambutan bore fruit, Dad, who was 92, would climb the tree.
Oh.
Slap back to his childhood.
Exactly. And they came to me and said, "Doctor, we want medicine. And we want medicine that will stop him from climbing trees." Exactly. So the answer to that is that there is no medicine to stop you from climbing a rambutan tree. But the son was ingenious. So what do you think the solution was? What do you think
Chop the
he
tree
did?
down.
Well, that would
Change
have
the
been
knob
an
again.
option. But the chopping is a good idea. So each time the tree flowered, they would remove the flowers. So the tree never ever bore fruit. And that's
Like no more triggers. Yeah.
Exactly. So family members are very creative. And drugs are just one part of the solution.
To control the symptoms and then
Yeah, but I think, besides I guess it sounds funny in hindsight, but like living in that day-to-day can be really difficult.
Of
And I
course.
not understand, besides like spending on like erratic behaviors, they also can get like temper, or they can throw tantrums, or they can get a bit violent, and it's not
Yes.
any fault of their own, it's because of the condition. So like how would you help in like when you are talking to the caregivers, like
How
would
do you
help?
support them? You see?
So there can be a lot done with regards to dementia education, just getting them to understand the disease, understand the person, because there's no one size fits all. Everyone is different. I work with my psychologist, and she helps a lot because it takes time for the person to open up, for the caregiver to explain what are the behaviors that are challenging, and then we teach them strategies. But of course, there's a very famous book on caregiving. It's called the 36-hour day, because we all have 24 hours and our own lives. So looking after a person is like adding another 12 hours to that day. So the 36-hour day, because it really is a lot of unpaid work. Yeah. And a lot of women are doing it at the prime of their lives. A lot of them are struggling with the challenges, but having a support network, being able to ask for help, these are all the important things that they need to do.
Would you say that they'll come to your clinic to ask for support, or do you have any programs, or do you hold any special like talks or anything for these people?
They do come. I have a caregiver. She's a professional. She's actually a nurse. So she comes to my clinic just to cry, because she's so acutely stressed with all the multiple roles that she's juggling. So we
You just need an outlet for them.
exactly, and it takes a lot of trust. I mean, if I don't trust you, I won't come and cry.
And also the rapport as well, right?
Yeah.
Yeah, so I think I just give her that space. But of course, I'm just a doctor. And I enlist the help of my psychologist. We are tapping into grants available. Like AIC has a caregiver training grant where you can claim a few $100s a year for programs that help to support you. Exactly. Yeah.
Right. So being in community, like setting up your own community clinic for a while now, like how do you feel about the whole space? How do you feel about the state of geriatric care in Singapore? Do you feel like what are some of the things that you think can be improved on, or like some of the things that you hope in the future?
I'm positive about it because we make our own future. Even now, I feel that older people, they know what they want, and they are creating the future that they envision.
Sounds good. Yeah, and also really thankful for like all this very insightful sharing from you to our audience just now. And then if you were to ask to give some key messages to the audience, like the patients or even like the caregivers, what would you want to tell them out there?
I think we should be positive about aging. I'm here to counter ageism, which is discrimination against older people. I would love the opportunity to live a long life, and I think everybody should too as well.
Yeah.
Right?
So
Well,
we
you
shouldn't.
also know
We should look forward to aging.
Exactly.
Aging and then age gracefully.
Gracefully.
Especially seeing the weightlifting amas, right, on social media. I mean, you can see that.
And the strong silvers as well.
Yeah, so
Exactly.
inspiring.
Yeah, right.
So we can age beautifully, and we can age strong and healthily with a geriatrician to help you. All right. Thank you so much, Dr. Farhan.
It's been my pleasure. Thank you.
See you guys.